Hello, colleagues, ladies and gentlemen. I'm Andrew Coates, President of the Heart Failure Association, the ESC. It's my great pleasure to give this presentation on upcoming heart failure trials in 2022. And I'll focus on three important trials that we'll see the results of over the next few months: the DELIVER trial, DIAMOND trial, and the IRONMAN trial. Here are my declarations. First of all, the DELIVER trial. That's a really important trial. This I'm taking from the clinicaltrials.org site, but also the design paper from Scott Solomon earlier last year. It's a double-blind randomized trial, a very large trial, dapagliflozin 10 milligrams once a day or placebo, 6,263 patients actually enrolled, and estimated study completion date coming up next month. Now, I've heard that that's definitely on track. It's too late to be presented at the ACC. It's likely to be presented at a meeting in the middle of the year, or possibly August, September-ish in the Northern Hemisphere. This is a very important trial because it's, if you like, the sister trial to Emperor Preserve, the trial of empagliflozin. This is the trial of dapagliflozin in the treatment of HFpEF. The primary outcome is time to first occurrence of any of the components of CV death, hospitalization for heart failure, or urgent heart failure visit, which is sort of like hospitalization-like events, emergency department or outpatients. And it's going to be assessed in the full study population and also in the subpopulation with ejection fractions less than 60%. You remember all patients are 40% and above, so they're looking at it in the 40 to 60% range, and then separately in all patients, including those above 60. Important secondary outcomes: total heart failure events, change from baseline in the KCCQ total symptom score, the probably best validated measure of quality of life in heart failure, and of course, time to cardiovascular mortality and time to any mortality. Importantly, it includes both clinic patients, ambulatory, as well as hospitalized patients, provided they've been off IV heart failure medication for at least 24 hours. Why this is so important is I'd like to just backtrack a little bit and look at the two major SGLT2 inhibitors that have now recommended for heart failure. And there's a long history here. If you go back to the cardiovascular outcome trials in type 2 diabetes, we have on the left empagliflozin that has positive results. You see in pink, all those are significant, very significant reduction in heart failure hospitalization, very significant reduction in cardiovascular mortality, and a significant reduction in the primary endpoint of 3-point MACE. On the right, the DECLARE TIMI 58 trial, which is very similar to dapagliflozin and very large, it was positive for heart failure hospitalization, but wasn't as impressive as EMPA was for CV death or 3-point MACE. So in this sense, in this setting, type 2 diabetics with established atherosclerotic cardiovascular disease or at high risk, EMPA looked better than DAPA. Then you turn to SGLT2 inhibitors in HFrEF, and you see that we get similar results for heart failure hospitalization between the two, EMPA on the left, DAPA on the right. We get similar reductions in the composite endpoint of CV death or heart failure hospitalization. But in this case, the DAPA does better. It's got a significant effect on CV mortality that wasn't seen with empagliflozin. So now we've got the opposite we had in type 2 diabetes. Within heart failure, we've got DAPA looking slightly better. Now we turn to CKD, another condition with SGLT2 inhibitors cause major benefits, and we see the composite renal outcome is significantly improved by dapagliflozin. We also get a reduction in all-cause of death, which is significant, and in the composite of CV death or heart failure hospitalization. We haven't as yet had the EMPA kidney trial presenting, but that's a similar trial to DAPA CKD, slightly different type of kidney patients, but that'll be very exciting. So DAPA has got it's ahead in that regard. But now we turn to SGLT2 inhibitors in HFpEF, and EMPA's ahead because its trial, EMPA Reduced, is already reported, and a significant effect on the primary endpoint of CV death or heart failure hospitalization, a significant effect on heart failure hospitalization, but a non-significant trend on CV death. What's DAPA going to show? Will it be like EMPA Reduced and DAPA HF, where DAPA's better? Or will it be one of those where they're both the same? This is a tussle between two fantastic drugs. One gets ahead, the other gets ahead. Probably they're more alike than they are different. The second one is the DIAMOND trial, and that's a phase 3B multinational placebo-controlled randomized withdrawal study, and it's looking at the use of a potassium binder called Potassium. It's recruited 878 participants, and it started in 2019. It actually completed September last year, and it was cut short due to the difficulties, the impact of the COVID pandemic on conducting the trial. It'll be presented. It's down there for the late-breaking abstracts in the American College of Cardiology, so just next month. The background to this trial is that we know that guideline-recommended medical management of RASI is difficult in the setting of hyperkalemia. It's the most common reason for RASI drugs, ACE inhibitors, ARBs, ARNIs, or MRAs, to be withdrawn, because when you get high serum potassiums, you really, in many historical guidelines, you had to reduce or discontinue the dose of these RASI drugs. And potentially that means that you're not getting the potential benefit of these drugs. So this is an option where maybe we could manage the high potassium levels and allow these drugs to continue. If you have an episode of hyperkalemia, it's very common, more than half the cases, where you actually get either a reduction in dose or you actually cease the RASI dose. And once you cease, the chance of getting back is quite low. The period off RASI protection can be very prolonged. Down titration or discontinuation of RASI due to hyperkalemia is associated with a doubling of mortality across various different patient subtypes, CKD, stages 3 to 4, heart failure or diabetes, particularly in heart failure. So having hyperkalemia where it leads to discontinuation of RASI is a sign of a very dangerous outcome. And we really try and avoid this if we can. So how do we deal with it? Well, we did this analysis of the European Heart Failure Long-Term Registry, and it's looking at the risk of having high potassium levels, but then it's adjusting it for what actually happens. And if you get an episode of hyperkalemia and you lead to discontinuation of ACE inhibitor, discontinuation of ARB, or discontinuation of the MRA, you get a very dramatically increased risk of mortality between 7 and 13-fold. But if, despite those hyperkalemia, you actually can maintain those, if you control for the effect of discontinuing the RASIs, you actually find that the potassium levels do not predict mortality. So it appears that most of the increased mortality risk in patients with heart failure with hyperkalemia is due to the fact that doctors use that as a reason to stop the RASI. It's not the hyperkalemia itself that appears to be the thing that's causing the increased risk. So what can we do about it? Well, there are two novel potassium binders. We've had potassium binders for many years, but the old historical ones, CPS and SBS, are really unpleasant to take and have high risk of causing gastrointestinal complications, including quite serious. These are two new potassium binders that are much better tolerated, and they can effectively and gently reduce potassium level and keep them down long term. They've been subject to a number of modest-sized trials that show they can be taken regularly, they can control high potassium levels, and they can allow higher doses of RASIs to be used in a number of conditions such as CKD and hypertension. The DIAMOND trial is an interesting design. You see here, patients must meet the following criteria. They must be on a RASI, they must have HFrEF, ejection fraction equal to or below 40%, GFRs above 30, elevated in BNP and N-terminal proBNP. And they need to have either not been able to go to full dose RASI or had a history of inability to take that because of high potassium levels, or they can be hyperkalemic requiring treatment. Then the run-in phase, which was single blind up to 12 weeks, initiated the potassium binder Potassium, and during that phase, then the physicians were asked to optimize ACE, ARB, ARNI, and initiate or optimize MRA. At the end of that 12-week period, they were then randomized to either continue Potassium or withdraw the Potassium on the hypothesis that patients who had Potassium withdrawn are likely to get recurrence of hyperkalemia, and that may lead to a reduction of RASI dose and may lead to adverse clinical outcomes. The primary endpoint was the change in potassium level caused by this strategy of continuing bacteremia, but there were 5 hierarchical pre-specified secondary endpoints, including one which was a win ratio, which looked at the incidence of all-cause mortality, cardiovascular hospitalization, and the use of various dose levels of ACE, ARB, ARNI, MRA, or beta blocker. We haven't got the results of this trial. It'll be presented, as I said, next month at the ACC. The last trial we're looking forward to is the Ironman trial. That has implications for iron therapy. It's an open label randomized trial of IV iron isomaltose, 10 milligrams, not 10 milligrams, isomaltose, 1,300 patients, infused over 15 minutes and dose of 1,000 to 2,000 milligrams. Started in August 2016. It completes next month. The primary endpoint is CV mortality or hospitalization for worsening heart failure, and it includes patients with HFrEF ejection fractions below 45%, NYHA class 2 to 4, and a conventional iron deficiency defined by TSAT less than 20% and or ferritin less than 100 micrograms per ml, enhanced for risk of heart failure, including patients with recent heart failure hospitalization and elevated natriuretic peptides. The reason this trial is important is we have recommendations for the identification of iron deficiency in patients with heart failure in the European guidelines, class 1 recommendation that all patients with heart failure should be periodically screened for anemia and iron deficiency. And in the presence of iron deficiency, intravenous iron supplementation with one formulation and one formulation only, ferric carboxymaltose, should be considered to improve exercise capacity and quality of life. Intravenous iron using ferric carboxymaltose should also be considered in symptomatic heart failure patients recently hospitalized for heart failure with ejection fractions below 50% and who are iron deficient to reduce the risk of heart failure hospitalization. That's also a class 2A recommendation, and that's based on the AFFIRM AHF trial. Ferric carboxymaltose should be considered for iron deficiency, defined that same way to improve symptoms and reduce hospitalization in the pre-discharge and early post-discharge follow-up page for patients hospitalized for acute heart failure. That's because of this trial, the AFFIRM AHF trial, that showed a very strong trend to reduction in the primary outcome of total heart failure hospitalizations and CV death, a significant effect on heart failure hospitalization, but no effect on CV mortality. This was done in the COVID era and a pre-specified subgroup analysis censoring from when the first COVID came along. If you take that into account, it was a significant reduction. So we are confident that we can treat acute heart failure in the pre-discharge phase with intravenous ferric carboxymaltose. Now this new trial, Ironman, will extend this to patients also with stable outpatients, look at a major outcome, and actually another iron formulation, isomaltose, extending our options for the treatment of iron deficiency and heart failure. So these are very important 3 trials, and we look forward to these results. It should be coming out over the next few months. Thank you all very much.